Emang udah tak suruh masuk jam anu?
Udah, dimasukin.
Masukin aja. Emang buka jam segitu. Wah, aku belum
Wes.
host ini ya.
Udah 2 orang.
Jadi lagi, guys.
Saya tak hostkan. Saya. Oke.
Videonya Mbak Kuni.
Mbak Kuni videonya.
Oh, aduh, aku harus pakai video ya Mas ya?
Wih, udah pada kumpul ini yang lain.
Malah mukanya Mbak Kuni yang keluar.
Video yang tadi
Mbak Kuni, ya Allah. Mbak Kuni, ya Allah, Mbak.
Ya, di-share.
Udah.
Apakah yang dimaksud dengan COVID-19? COVID-19 merupakan penyakit infeksi saluran pernafasan akibat jenis virus corona yang baru dan ditemukan pada tahun 2019 di Wuhan, China. Gejala yang dapat muncul akibat COVID-19 antara lain sesak nafas, sakit kepala, nyeri tenggorokan, batuk, dan demam. Lalu bagaimanakah cara kita melindungi diri dan mencegah penyebaran penyakit COVID-19? Pertama, cuci tangan 6 langkah menggunakan sabun dan air mengalir atau hand sanitizer. Kedua, jaga jarak 1 meter saat berinteraksi dengan orang lain agar percikan saat bersin, batuk, maupun berbicara tidak terhirup oleh kita. Ketiga, hindari menyentuh area hidung, mulut, maupun mata agar virus tidak masuk dalam tubuh kita. Keempat, tetap tinggal di rumah dan segeralah cari pertolongan apabila Anda sakit. Kelima, gunakan masker secara tepat. Keenam, gunakan kacamata untuk melindungi mata dari percikan. Masker mempunyai peran penting untuk pencegahan penyebaran penyakit COVID-19. Yuk, kita pelajari lebih mendalam tentang masker. Masker yang sering kita jumpai ada 3 macam, yaitu masker bedah, masker N95, dan masker kain. Masker bedah digunakan oleh tenaga medis khususnya atau pasien yang sedang sakit. Masker ini dapat dijadikan pilihan dalam menangkal virus corona karena terdiri atas 3 lapisan yang efektif menahan 95% percikan atau droplet. Masker N95 digunakan oleh tenaga medis yang kontak langsung dengan pasien COVID-19. Masker ini tidak disarankan untuk penggunaan sehari-hari karena desainnya menyebabkan sulit untuk bernafas. Sedangkan masker kain untuk umum dapat membantu mengurangi kelangkaan masker untuk tenaga medis. Masker kain dapat digunakan oleh masyarakat saat harus keluar rumah atau berinteraksi dengan orang lain. Penggunaan masker kain tidak boleh lebih dari 4 jam. Kemudian kita harus berganti masker kain yang bersih. Masker yang sudah dipakai atau kotor harus dicuci dan dikeringkan. Lalu, bagaimana cara menggunakan dan melepas masker? Sebelum menggunakan masker, kita harus cuci tangan terlebih dahulu. Kemudian pegang tali, pasang pada telinga. Pastikan hidung, mulut, dan dagu tertutup oleh masker. Bagian masker yang berwarna harus berada di luar. Tekan bagian masker yang terdapat kawat agar mengikuti bentuk hidung. Lepas masker yang telah digunakan dengan memegang bagian tali tanpa menyentuh kain masker. Masker kain yang telah dipakai 4 jam harus dicuci bersih dan kemudian dikeringkan. Atau buang masker sekali pakai yang telah digunakan ke tempat sampah. Kemudian segeralah cuci tangan dengan sabun. Marilah kita bersama-sama menghentikan penyebaran COVID-19 dengan tetap di rumah dan menggunakan kacamata serta masker apabila terpaksa keluar rumah. Tahukah kamu bahwa sejak awal tahun 2020, Indonesia sedang menghadapi wabah virus corona? Virus ini merupakan keluarga dari virus penyebab SARS dan berasal dari kota Wuhan di Cina. Virus corona, penyebab penyakit SARS dan COVID-19 merupakan virus yang menginfeksi saluran pernafasan kita yang biasa disebut pneumonia atau radang paru-paru. Sejak bulan Maret, seluruh masyarakat Indonesia diajak oleh pemerintah untuk bersama-sama menghadapi wabah ini. Hal ini harus dilakukan karena penyebaran virus corona meningkat dengan sangat cepat di seluruh wilayah Indonesia. Hingga saat ini telah diketahui 7.000 orang positif terjangkit virus corona. Oleh karena itu, marilah kita bersama-sama mempelajari cara penyebaran dan pencegahan dari penyakit ini. Virus corona dapat ditularkan melalui percikan atau droplet. Saat kita sedang bersin, batuk, maupun berbicara, kita berpotensi mengeluarkan droplet atau percikan. Percikan ini dapat menempel pada benda-benda di sekitar kita maupun yang kita sentuh, seperti saklar lampu atau ponsel. Apabila kita menyentuh benda yang terjangkit virus, maka kita mendapati virus corona pada badan kita, sehingga kita dapat menjadi sumber penularan. Namun, kita tidak akan menjadi sakit asalkan virus tidak masuk ke dalam tubuh melalui hidung, mulut, ataupun mata. Jangan lupa gunakan kacamata dan masker untuk mencegah percikan masuk ke dalam mata, hidung, dan mulut. Hindari memucuk mata agar virus corona tidak masuk ke dalam mata. Oleh karena itu, marilah kita sering mencuci tangan dan belajar cuci tangan yang benar. Bagaimana mencuci tangan dengan benar? Yuk kita simak bersama. Cuci tangan dapat dilakukan dengan air mengalir maupun dengan hand sanitizer selama 20 detik. Jangan lupa cuci tangan menggunakan sabun apabila kita menggunakan air yang mengalir. Pertama, ratakan seluruh sabun atau hand sanitizer pada seluruh telapak tangan dengan gerakan memutar. Kedua, gosok punggung tangan dengan cara bergantian kanan dan kiri. Ketiga, bersihkan sela-sela jari tangan dengan cara saling mengikatkan tangan kanan dan tangan kiri. Keempat, kuncikan telapak tangan kanan dan telapak tangan kiri, lalu gerakkan memutar. Kelima, genggam ibu jari dan lakukan gerakan memutar, dilakukan bergantian tangan kanan dan tangan kiri. Keenam, kunjukkan ujung jari dan gosokkan kuku pada telapak tangan. Dilakukan bergantian tangan kanan dan tangan kiri. Terakhir, bilas sabun hingga bersih dan segera keringkan dengan lap bersih. Apabila menggunakan hand sanitizer, setelah 6 langkah tidak perlu dibilas dan hanya ditunggu hingga kering. Mudah bukan? Mari kita bersama-sama memutus rantai penyebaran virus corona dengan sering cuci tangan dan melakukannya dengan benar. Tetaplah di rumah dan gunakan kacamata serta masker jika terpaksa keluar rumah. Semua orang bisa menjadi pahlawan dengan melakukan hal kecil ini.
Kisah ini diambil dari kisah nyata. Menunggu untuk dimengerti. Surat itu sampai. Surat pertama yang menyatakan hasil swab pasien PDP. Aku membaca hasilnya. Di antara 5 nama yang tertera, aku temukan salah satu nama yang aku kenal. Iya, dia perawatku. Ia terkonfirmasi positif. Aku tak sanggup seandainya terjadi hal buruk pada dirinya. Dia perawat yang paling aku andalkan untuk berjuang di garda terdepan. Dia juga seorang suami dari istri yang sedang hamil muda dan seorang ayah dari putra yang berusia 2 tahun. Dia sudah dirawat di ruang isolasi rumah sakit selama 5 hari karena demam tinggi. Menunggu hasil swabnya dengan cemas. Dengan berat hati aku berkata, "Maaf, kamu positif." Dengar suaranya terdiam di seberang sana dan berkata, "Saya justru bersyukur, dokter. Saya telah mendapatkan vaksin alami dari Allah. Pengorbanan saya sekian hari mengisolasi diri akhirnya diganjar Allah dengan antibodi. Memang saya sudah ditakdirkan menjadi perawat pasien COVID. Biarlah terbentuk kekebalan di tubuh saya agar saya lebih berani merawat mereka nanti. Semoga imunitas ini menjadikan saya lebih ikhlas." Gemetar aku mendengarnya. Teringat senyum antusiasnya saat ia menerima tugas berat ini. Ia yang paling aku andalkan. Tapi ia adalah pasien pertama kami yang terkonfirmasi positif. Hari ke-8 ia batuk hebat. Foto toraks yang awalnya bersih perlahan muncul infiltratnya. Badannya semakin lemas, nafasnya semakin sesak. Suaranya pun semakin agak parau. Hampir setiap hari aku menelponnya dan memastikan ia tidak bertambah buruk. Namun hari demi hari berlalu. Tepat di hari ke-16 rawat inap, ia telah melewati hari-hari terburuknya. Ia berkata, "Alhamdulillah, saya bahagia sekali, dok. Sedikit pun tak ada rasa penyesalan. Hal ini membuat saya tambah semangat, dok. Semangat sekali. Tapi aku tahu pasti masalah belum selesai hingga di sini. Masih ada masalah sosial yang harus kami hadapi di luar sana. Akankah masyarakat masih mau menerimanya? Masihkah ada yang bersedia hidup bertetangga dengannya di saat tempat lain ada nakes yang diusir dari kosnya? Masih adakah yang bersedia untuk sekedar menyapanya saat di seberang sana ada rumah seorang dokter spesialis yang disegel tanpa seizin yang punya? Masih adakah rasa peduli itu? Adakah tempat di hati mereka bagi kami yang menjadi korbannya? Teruntuk mereka yang menganggap hidupnya lebih berarti daripada kami yang telah mengorbankan diri, semoga cerita ini bisa membuka mata batin dan melembutkan kerasnya hati yang tidak mau mengerti. Meski hanya untuk sekedar berbagi ruang dan waktu di bumi pertiwi ini.
yang dimaksud dengan COVID-19? COVID-19 merupakan penyakit infeksi saluran pernafasan akibat jenis virus corona yang baru dan ditemukan pada tahun 2019 di Wuhan, China. Gejala yang dapat muncul akibat COVID-19 antara lain sesak nafas, sakit kepala, nyeri tenggorokan, batuk, dan demam. Lalu bagaimanakah cara kita melindungi diri dan mencegah penyebaran penyakit COVID-19? Pertama, cuci tangan 6 langkah menggunakan sabun dan air mengalir atau hand sanitizer. Kedua, jaga jarak 1 meter saat berinteraksi dengan orang lain agar percikan saat bersin, batuk, maupun berbicara tidak terhirup oleh kita. Ketiga, hindari menyentuh area hidung, mulut, maupun mata agar virus tidak masuk dalam tubuh kita. Keempat, tetap tinggal di rumah dan segeralah cari pertolongan apabila Anda sakit. Kelima, gunakan masker secara tepat. Keenam, gunakan kacamata dan penyebaran penyakit COVID-19. Yuk, kita pelajari lebih mendalam tentang masker. Masker yang sering kita jumpai ada 3 macam, yaitu masker bedah, masker N95, dan masker kain. Masker bedah digunakan oleh tenaga medis khususnya atau pasien yang sedang sakit. Masker ini dapat dijadikan pilihan dalam menangkal virus corona karena terdiri atas 3 lapisan yang efektif menahan 95% percikan atau droplet. Masker N95 digunakan oleh tenaga medis yang kontak langsung dengan pasien COVID-19. Masker ini tidak disarankan untuk penggunaan sehari-hari karena desainnya menyebabkan sulit untuk bernafas. Sedangkan masker kain untuk umum dapat membantu mengurangi kelangkaan masker untuk tenaga medis. Masker kain dapat digunakan oleh masyarakat saat harus keluar rumah atau berinteraksi dengan orang lain. Penggunaan masker kain tidak boleh lebih dari 4 jam. Kemudian kita harus berganti masker kain yang bersih. Masker yang sudah dipakai atau kotor harus dicuci dan dikeringkan. Lalu, bagaimana cara menggunakan dan melepas masker? Sebelum menggunakan masker, kita harus cuci tangan terlebih dahulu. Kemudian pegang tali, pasang pada telinga. Pastikan hidung, mulut, dan dagu tertutup oleh masker. Bagian masker yang berwarna harus berada di luar. Tekan bagian masker yang terdapat kawat agar mengikuti bentuk hidung. Lepas masker yang telah digunakan dengan memegang bagian tali tanpa menyentuh kain masker. Masker kain yang telah dipakai 4 jam harus dicuci bersih dan kemudian dikeringkan. Atau buang masker sekali pakai yang telah digunakan ke tempat sampah. Kemudian segeralah cuci tangan dengan sabun. Marilah kita bersama-sama menghentikan penyebaran COVID-19 dengan tetap di rumah dan menggunakan kacamata serta masker apabila terpaksa keluar rumah. Tahukah kamu bahwa sejak awal tahun 2020, Indonesia sedang menghadapi wabah virus corona? Virus ini merupakan keluarga dari virus penyebab SARS dan berasal dari kota Wuhan di China. Virus corona, penyebab penyakit SARS dan COVID-19 merupakan virus yang menginfeksi saluran pernafasan kita yang biasa disebut pneumonia atau radang paru-paru. Sejak bulan Maret, seluruh masyarakat Indonesia diajak oleh pemerintah untuk bersama-sama menghadapi wabah ini. Hal ini harus dilakukan karena penyebaran virus corona meningkat dengan sangat cepat di seluruh wilayah Indonesia. Hingga saat ini telah diketahui 7.000 orang positif terjangkit virus corona. Oleh karena itu, marilah kita bersama-sama mempelajari cara penyebaran dan pencegahan dari penyakit ini. Virus corona dapat ditularkan melalui percikan atau droplet. Saat kita sedang bersin, batuk, maupun berbicara, kita berpotensi mengeluarkan droplet atau percikan. Percikan ini dapat menempel pada benda-benda di sekitar kita maupun yang kita sentuh, seperti saklar lampu atau ponsel. Apabila kita menyentuh benda yang terjangkit virus, maka kita mendapati virus corona pada badan kita, sehingga kita dapat menjadi sumber penularan. Namun, kita tidak akan menjadi sakit asalkan virus tidak masuk ke dalam tubuh melalui hidung, mulut, ataupun mata. Jangan lupa gunakan kacamata dan masker untuk mencegah percikan masuk ke dalam mata, hidung, dan mulut. Hindari mengucek mata agar virus corona tidak masuk ke dalam mata. Dan belajar cuci tangan yang benar. Bagaimana mencuci tangan dengan benar? Yuk kita simak bersama. Cuci tangan dapat dilakukan dengan air mengalir maupun dengan hand sanitizer selama 20 detik. Jangan lupa cuci tangan menggunakan sabun apabila kita menggunakan air yang mengalir. Pertama, ratakan seluruh sabun atau hand sanitizer pada seluruh telapak tangan dengan gerakan memutar. Kedua, gosok punggung tangan dengan cara bergantian kanan dan kiri. Ketiga, bersihkan sela-sela jari tangan dengan cara saling mengikatkan tangan kanan dan tangan kiri. Keempat, kuncikan telapak tangan kanan dan telapak tangan kiri, lalu gerakkan memutar. Kelima, genggam ibu jari dan lakukan gerakan memutar, dilakukan bergantian tangan kanan dan tangan kiri. Keenam, kuncupkan ujung jari dan gosokkan kuku pada telapak tangan, dilakukan bergantian tangan kanan dan tangan kiri. Terakhir, bilas sabun hingga bersih dan segera keringkan dengan lap bersih. Apabila menggunakan hand sanitizer, setelah 6 langkah tidak perlu dibilas dan hanya ditunggu hingga kering. Mudah bukan? Mari kita bersama-sama memutus rantai penyebaran virus corona dengan sering cuci tangan dan melakukannya dengan benar. Tetaplah di rumah dan gunakan kacamata serta masker jika terpaksa keluar rumah. Semua orang bisa menjadi pahlawan dengan melakukan hal kecil ini.
Kisah ini diambil dari kisah nyata. Menunggu untuk dimengerti. Surat itu sampai. Surat pertama yang menyatakan hasil swab pasien PDP. Aku membaca hasilnya. Di antara 5 nama yang tertera, aku temukan salah satu nama yang aku kenal. Iya, dia perawatku. Ia terkonfirmasi positif. Aku tak sanggup seandainya terjadi hal buruk pada dirinya. Dia perawat yang paling aku andalkan untuk berjuang di garda terdepan. Dia juga seorang suami dari istri yang sedang hamil muda dan seorang ayah dari putra yang berusia 2 tahun. Dia sudah dirawat di ruang isolasi rumah sakit selama 5 hari karena demam tinggi. Menunggu hasil swabnya dengan cemas. Dengan berat hati aku berkata, "Maaf, kamu positif." Ku dengar suaranya terdiam di seberang sana dan berkata, "Saya justru bersyukur, dokter. Saya telah mendapatkan vaksin alami dari Allah. Pengorbanan saya sekian hari mengisolasi diri akhirnya diganjar Allah dengan antibodi. Memang saya sudah ditakdirkan menjadi perawat pasien COVID. Biarlah terbentuk kekebalan di tubuh saya agar saya lebih berani merawat mereka nanti. Semoga abilitas ini menjadikan saya lebih ikhlas. Gemetar aku mendengarnya. Teringat senyum antusiasnya saat ia menerima tugas berat ini. Ia yang paling aku andalkan. Tapi ia adalah pasien pertama kami yang terkonfirmasi positif. Hari ke-8 ia batuk hebat. Foto toraks yang awalnya bersih perlahan muncul infiltratnya. Badannya semakin lemas, nafasnya semakin sesak. Suaranya pun semakin agak parau. Hampir setiap hari aku menelponnya dan memastikan ia tidak bertambah buruk. Namun hari demi hari berlalu. Tepat di hari ke-16 rawat inap, ia telah melewati hari-hari terburuknya. Dan ia berkata, "Alhamdulillah, saya bahagia sekali, Dok. Sedikit pun tak ada rasa penyesalan. Hal ini membuat saya semakin sadar bahwa banyak yang peduli kepada saya. Saya tambah semangat, Dok. Semangat sekali." Tapi aku tahu pasti masalah belum selesai hingga di sini. Masih ada masalah sosial yang harus kami hadapi di luar sana. Akankah masyarakat masih mau menerimanya? Masihkah ada yang bersedia hidup bertetangga dengannya di saat tempat lain ada nakes yang diusir dari kosnya? Masih adakah yang bersedia untuk sekedar menyapanya saat di seberang sana ada rumah seorang dokter spesialis yang disegel tanpa seizin yang punya? Masih adakah rasa peduli itu? Adakah tempat di hati mereka bagi kami yang menjadi korbannya? Teruntuk mereka yang menganggap hidupnya lebih berarti daripada kami yang telah mengorbankan diri, semoga cerita ini bisa membuka mata batin dan melembutkan kerasnya hati yang tidak mau mengerti. Meski hanya untuk sekedar berbagi ruang.
Okay, Dr. Gavin, are you here? Good afternoon, Dr. Gavin. Oh, nggak bisa. Kok di-mute ya?
Hi, can you hear me?
Yeah, I can hear you. So, okay, Dr. Gavin, it's very nice to meet you. I am Nadia, the moderator for today. Okay, so
Nice to meet you again.
pardon? Yeah, I'm Nadia, the moderator for today. So, can you hear me?
Yes.
Okay.
Can you hear me? Thank you for inviting me to this talk.
Okay. So before we start, I would like to greet to all of the participants, to all audiences, good afternoon. Assalamualaikum warahmatullahi wabarakatuh. And the honor, the presenter, Dr. Gavin Tan from Singapore National Eye Center. And then also we have here Dr. Budi as head of Department of Ophthalmology. And we have also Dr. Ani as head of study program in ophthalmology, Brawijaya University. And so we have our head of Indonesia Ophthalmology Association, or Perdami, branch Malang Raya. So we have Dr. Seskwati Prayitnaningsi. And in this occasion, Dr. Seskwati would like to give a welcome speech. So please, Dr. Seskwati, the time is yours.
Thank you, Dr. Nadia. Assalamualaikum warahmatullahi wabarakatuh. Good evening, ladies and gentlemen. I would like to extend my warm welcome to all guests and participants from Indonesian Ophthalmologists Association Malang branch members, all staff members and residents of Ophthalmology Department, Universitas Brawijaya and Saiful Anwar Hospital. Our special appreciation to Dr. Gavin from Singapore National Eye Center as our webinar speakers. It is truly an honor for us to have you here to share your valuable knowledge and insights. I believe this scientific meeting will bring many benefits. As Dr. Nadia mentioned, this scientific meeting result from the collaboration from the IOA Branch Malang and the Department of Ophthalmology and also the study program of the Residency Ophthalmology Brawijaya University. And I do hope to collaborate with you in the future, Dr. Gavin, in the aspect of education, maybe a research, also in the medical practices as well. Also, I would like to thank Dr. Rose for connecting and helping us with Dr. Gavin. And finally, to all participants, thank you for your attendance and have a great webinar. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you, Dr. Seskwati, for your welcome speech. So in this, Okay, so in this very special day, it's such a great opportunity to us to having Dr. Gavin Tan as a speaker for diabetic retinopathy. So Dr. Gavin will give an hour talk about diabetic retinopathy from screening to management. I will read the summary of his CV. So Dr. Gavin Tan Si Wei, he is a senior consultant at Surgical Retinal Department at Singapore National Eye Center. He also clinician scientist at Singapore Eye Research Institute and lead for diabetic complication at Diabetes Center at SingHealth Duke, National University of Singapore. And Dr. Gavin graduated from National University of Singapore and attend several fellowship and several countries like Edinburgh and Singapore. And he has so many professional experience like when he's in Stanford and UCLA. Also, several awards has been given to him, such as award from American Academy of Ophthalmology, from APAO, and from ARVO, and many more. So the award is very so much award here. So and he has so many publication and reputable journal, and already achieved H index 27. So I guess we are so lucky to have him here. And now we give time to Dr. Gavin around 1 hour talk to present his presentation. So please, Dr. Gavin, the screen is totally yours.
Hi, thank you very, very much for inviting me and for that very kind introduction. I'm very happy to be able to give this talk. I'm very happy to be able to meet you all, and hopefully the next time after all these viral problems are over, we'll be able to meet at a face-to-face meeting in the future. So today I'm going to give my talk. Let me just get the screen sharing started on diabetic retinopathy today. And I'm going to cover a broad range of topics from screening to management. And I start with screening and management because I feel those are the two key areas that will enable us ophthalmologists to do what we seek to do, which is to prevent vision loss. So these are just my financial disclosures. So we all know diabetes is a global emergency. There are more than 400 million people worldwide affected. And we know about 100 over million will have some form of eye disease. We see this in the clinic all the time. Diabetic retinopathy is the most common microvascular complication of diabetes. a third of diabetics will have the retinopathy, and 10% will have the form that can cause vision loss. That means severe non-proliferative diabetic retinopathy or some form of diabetic macular edema. And we all know about the risk factors for diabetes from our medical school days. And we do know as well, this chart shows the costs of treating diabetics as the diabetic retinopathy gets more and more severe. The more severe it is, the more cost is going to be involved in treating those patients. And that brings us to the first point, key point in my presentation today. In diabetic retinopathy, screening is critical. And we know this because in the early stages of diabetic eye disease, it is asymptomatic. Even once you've got moderate non-proliferative diabetic retinopathy, patients don't even notice anything at all. But it does create this crucial time opportunity for intervention where we can prevent vision loss. And we know in proliferative diabetic retinopathy, we do laser. In diabetic macular edema, we treat with intravitreal injections. So being able to identify them is important. In areas where there's no screening or there's very poor access to eye care, we all know what happens. The patient comes to us when they have a sudden loss of vision. And that is usually because they have had bleeding or tractional retinal detachment. And at that point, it often becomes very difficult to salvage good vision for our patients with diabetic eye disease. So screening programs have been implemented around the world, and they do work. The countries that have managed to institute nationwide screening programs normally see a drop in diabetic-related blindness and vision loss anywhere from 5 to 10 years later. We know it doesn't happen straight away. In fact, when you first start the screening program, what's going to happen is you're going to find more people with diabetic eye disease because you're picking them up from the community. But if you pick enough of these patients up that need laser before they lose vision, you notice that a few years later, your annual incidence of diabetic blindness will fall. And we know there are quite well-established screening guidelines outside. Adults with type 1 diabetes tend to only need screening a few years after diagnosis. In type 2, because the onset is difficult to determine, and in Asia, the majority of diabetics are type 2, they should have some form of fundal examination at the time of diagnosis. And of course, for children and adolescents, there are certain different guidelines. So what are the current screening? Well, we do know that we feel all diabetic patients should have some form of regular eye checkup. And the eye checkup should be some form of retinal or fundus examination. The ICO published guidelines about 2 years ago, where they recommended that in patients who are new to diabetic diagnosis, or in patients who are known to have no diabetic eye disease or mild non-proliferative, you can get an examination every 1 to 2 years. Once they're mild, some patients you may want to increase the frequency to yearly. And if they're moderate or severe, then you need to see them more frequently. And obviously, if they reach PDR or diabetic macular edema, they need to be treated. How do you do this kind of screening in your population? There are many ways. We can see everybody with a slit lamp in the clinic. We know slit lamp examination is very, very good, but it's something that's not practical and is hard to do on scale because we just simply don't have enough ophthalmologists around in probably any country in the world, even in the rich developed countries. So what has become the most effective surrogate has actually been non-mydriatic fundus cameras. And the non-mydriatic fundus cameras allows essentially almost anybody, any technician, to capture an image of the fundus. And then you need to work out a system of interpreting these images so that you can identify the correct forms of disease. In Singapore, actually it is 10 years ago, we launched a national telemedicine-based diabetic retinopathy screening program. And this system used a telemedicine platform with non-mydriatic cameras at all the primary care clinics. And these images were sent back to central reading centers, where what we did was, even in this instance, you can't get enough ophthalmologists to read all the images. So we trained up what we call non-physician graders to provide interpretation of these images. And how it works is the image capture site. Images are sent via internet or the intranet to the reading center. the graders at the reading center who are trained technician interpret these images. We normally have a 2-reader system where a junior grader does the first pass, and a proportion of normal cases and all abnormal cases are read a second time by a second reader. And depending on the agreement or disagreement, we may escalate to get an ophthalmologist to arbitrate or regrade these images. And reports are then sent back to the diabetic clinicians in primary care to take some action. These are actually all numbers. We've read a few 100,000 images already. Most of the reports can be generated within an hour, some within a day, and the sensitivity and specificity of our reading center is good. When we implemented this, we were required by our Ministry of Health to do a regular audit, and our quarterly audit regularly provides a sensitivity of 95 to 96% and a specificity in the range of 86 to about 90%. In addition, our graders have been trained to not just read diabetic eye disease, but they've been trained to identify over the years all the other abnormalities that may be present in these images. So whether it's the presence of what we call referable diabetic retinopathy, which we classify as moderate or worse, or features that show a suspect diabetic macular edema, they get referred. But if they have abnormal glaucomatous appearing disc, signs of age-related macular degeneration or other pathology like an RVO, vein occlusion, they are also these diseases are also picked up and referred to the specialist clinic. So it's really critical to screen. The main mechanism that you need to implement to screen in the world is not going to be sending out your doctors to the community because there's just too many diabetics in the world. You need a telemedicine program. But even if you have a telemedicine platform to gather these images from the community, you still have a problem with reading and interpretation. You don't have enough ophthalmologists. You can train technicians like we have, but that's a challenge to do it in continuity forever. So what we also did on our side was to try and use technology. Technology here is called deep learning, to develop a computer program or algorithm that can interpret these images as good as our humans can. And this is really enabled by the technology called deep learning. I won't go too much into depth into that. But what we found was that using this kind of artificial intelligence screening, we can lower the cost of interpreting these images because you reduce your reliance on manpower for interpretation. So we found that our deep learning system had a very good AUC for detecting referable diabetic retinopathy. And these are the ROC curves for different kind of ethnic groups. We wanted to compare to make sure that it was not performing more poorly because of ethnic differences in the fundus images. And our AI program is called Selena. It did have an AUC of more than 90% compared to retina specialists. And it performed quite similarly to our human graders. What we did find was actually the AI was more sensitive for the vision-threatening form of diabetic retinopathy compared to our human graders, although the human graders was more specific. And we believe it's because in instances where there's one or two very small, fine neovascularization at the disc or elsewhere, in a human grader who is working a high volume, who has to grade a few hundred scans a day, they may occasionally miss one or two. The machine produces a very reproducible result and doesn't miss these conditions. And this is a representation of what our software was designed to pick up. In this case, the green areas are the areas that the software is identifying as abnormal. In this case of their neovascularization at the disc, it's picking them up. In diabetic macular edema, the AI is picking it up. In this case, the AI was picking up, this is the algorithm that picks up AMD. We have developed one to do that, and one to detect these abnormalities. This is a 0.9 disc, and it can pick up the abnormality in the cup disc ratio as well. And we have developed a program that has got our local regulatory clearance and also recently got CE mark for use in screening for diabetic eye disease. We put the images into the software loads these images, and it can generate a report. This is what it would have been running in real time on a PC. Obviously, if you run it on a big data server, it can do this kind of task at a very, very much faster rate. And in this case, there were features of diabetic eye disease, and it identified it as referable. So we are actually implementing this artificial intelligence technology into our system. As you saw in some of our earlier slides, we found the sensitivity of the software was actually better than our graders, but the software suffered a little bit on specificity. So what we have implemented in our system is a two-stage process where the AI interprets the image first, and abnormal images are reviewed to ensure that we don't end up with too many false positives going to the ophthalmologist with a referral. The preliminary outcomes of this introduction of the AI into our system shows that the sensitivity for referable diabetic retinopathy is more than 90%. The specificity, when you do it on a large population like that, is a bit lower, 80%, but because we are then sending all the abnormal images for human revetting or regrading, we are still able to avoid the false positive diagnosis of diabetic eye disease. We also applied our DISSUSPECT program, and it has a good sensitivity with a slightly lower specificity as well. So if you can screen for images for diabetic eye disease, you do photographs, you do your screening, you pick up the disease, and you send them for treatment. But is there anything else that has been changing or is new in terms of imaging and understanding diabetic eye disease or diabetic retinopathy? We used to always traditionally use fundus photography, and in screening, we tend to use two-field. In the old days, when we used to assess patients for trials or to document the disease, we would do a 7-field ETDRS photo. But we know in this day and age, almost nobody does a 7-field anymore. It's really become obsolete. And there are many new imaging modalities available that can replace or give us more information on our diabetic patients. I just wanted to highlight a few that are emerging or being implemented in with greater access today, and that's optical coherence tomography and angiography and ultra-wide field imaging. So in ultra-wide field imaging, we do have scanning laser ophthalmoscopes that enables you to take an image of the whole retina, including the periphery at one go. And it gives it with essentially almost stunning kind of detail, which allows us to identify disease that would have been easily missed. If you compare with the 7-field ETDRS, we are picking up a lot of areas of disease that's not picked up on this kind of photography. Even if you compare with slit lamp biomicroscopy, you usually will not be able to go beyond this area of examinations. Maybe with a binocular indirect ophthalmoscope, you can. So studies have found that 7-field imaging is able to identify new vessels in areas where 2-field screening would have missed it. And the severity of images were the same in 85% of images, whereas the rest of the 15% of images were actually graded as worse disease if you do a wide field imaging. And for patients who had FA done, wide field imaging also demonstrated a lot more disease than standard imaging. So what's that implication? Well, you may say, if I do a good binocular indirect examination, I can pick some of this disease up. But what this allows you to do is actually quantify the amount of disease outside of the central area. And there has been one good longitudinal study which has shown that the presence of disease in the peripheral area is predictive or associated with a higher risk of progression. So this peripheral disease is worse. And we do know that diabetes is a disease of the periphery. There's more peripheral non-perfusion compared to central non-perfusion, and perhaps finding these changes in the periphery will be able to change the way we manage these patients, because we know these are the ones that are going to be at higher risk. The other technology I would like to highlight that will allow us to better evaluate our patients with diabetic retinopathy is OCT angiography. This is a non-invasive angiography technique where you use your OCT machine, and the OCT machine then takes multiple images at the same position. And by measuring the change of images with time, they can estimate using some form of image algorithms the amount of blood flow there is in the vessels. And that blood flow can be demonstrated on an on-fast image that actually represents an angiogram. If you're wondering how this works, you could look at this picture here. Essentially, this is a waterfall And what you're doing is you're taking multiple pictures of the waterfall, you're filtering out everything that doesn't move, and the only thing that is left on the image is the area where there's motion. And in our eyes, if the patient is not moving, is being cooperative, the only thing that should be moving is the red blood cells in the blood vessels. So OCTA is useful in diabetic retinopathy because it allows us to do non-invasive assessment of the foveal avascular zone. And we know when there's foveal avascular zone abnormalities, it portends the patient will have macular ischemia and a poorer visual potential. This has been compared with the functional microperimetry changes, and they find that it does actually represent these changes very well. So you can estimate the visual potential of these patients by looking at the foveal avascular zone on OCT angiography. OCTA can also be used to pick up suspect cases of proliferative diabetic retinopathy. In most instances, you can identify the new vessels clinically, but we always do have cases where some of the new vessels are a bit borderline or dubious, and you're unsure if this is just an ERMA or just a telangiectatic vessel. OCTA can identify whether these vessels are new vessels, because you will be able to identify in new vessels, you know it has to penetrate the ILM into the vitreous. And by looking at the on-fast image of the abnormal vessel and looking at a cross-sectional image, which shows the location of the abnormal vessel, we can identify if these vessels are new vessels or not without doing a dye angiography. And these findings tend to correspond very well with dye angiography if you did it. We also know the overall appearance of the OCTA does correlate well with diabetic retinopathy severity. We have found that looking at the central images, looking at the central angiogram, the more severe the diabetic retinopathy, the more capillary fallout breakdown you will find. And you also now have available newer and faster OCTA devices that no longer just take, the original devices could only do a 3x3 angiogram, which is very limited. Then you went to 6x6. Now you have machines that can do 12x12. And because the scanning laser speed is faster, you are able to get good montages that essentially gives you almost a full angiogram of disease. And this is, for example, a patient with a severe proliferative diabetic retinopathy. You can see the new vessels, you can see all the capillary fallout in these patients without having to do a formal angiogram. We have also done some research to look at the changes in the peripheral area compared with the central area on OCT angiography. And we did find that the changes in the periphery, as we would expect, are more severe when the diabetic retinopathy gets more severe. And these changes in the periphery are more important than the changes in the posterior region when you want to estimate severity. So this information may be useful in helping us then predict which eyes are actually more severe based on the actual capillary non-perfusion, instead of what we're doing now, which is looking for hemorrhages. And hemorrhages at the end of the day are just a surrogate sign of severity and don't tell us about the actual non-perfusion itself. There have also been multiple studies that have shown that some metrics, the non-perfusion, can actually predict the future progression of retinopathy or development of macular edema. And there have been some studies that show that changes in terms of the microaneurysm presence or breakdown the deep layers on OCTA can sometimes predict how well these patients will respond to our anti-VEGF therapy. And of course, in clinical practice, you would be able to use these imaging modalities together, looking at the ultra-wide images, doing the angiogram on the OCT machine. And in this case, he also had a normal dye angiogram, and you can see the findings are very, very consistent. And that gives you the confidence in future. I think it is more and more likely that we will very, very rarely need to do fluorescein angiograms, and we'll be relying on OCTA for most of our evaluation of retinal diseases, if not already. So multimodal imaging in diabetic retinopathy with wide angle images and OCTA will improve our understanding. It will allow us to better predict progression. And I think at the end of the day, once these devices are widely available, we're going to grade DR severity differently, because our old metric of using the photograph is really, really dated and limited. But we really need more data, especially long-term longitudinal prospective studies, to understand what all these imaging biomarkers really mean and predict, and that will allow those to become standard of care. So I've gone through screening of diabetic eye disease and talked a little bit about imaging. Now I'm going on to move on to an update on the management of diabetic eye disease. We all know the mild cases really are not managed by us. They are managed by the primary care or the diabetic physician, and that involves optimization of systemic therapy. We know that even if the eye disease gets to the moderate stage, we're really just monitoring for progression or deterioration to these stages where we would actually treat. And treatment has remained quite standardized into either laser or some form of anti-VEGF. This just goes to show that we are trying to address the underlying pathophysiology when we manage the disease. We're not doing things randomly. We know that, VEGF is a key mediator in most of our diseases, and that's why we give anti-VEGF has worked so well. We know that the ischemic and the hypoxia is the thing that drives a lot of disease, and that's why laser photocoagulation that destroys the hypoxic or ischemic retina works very well. Taking one step back, systemic management is also very important. We don't do it, but we should be aware that glycemic control, blood pressure control is important. And in terms of which blood pressure drug tends to be the best, it has been shown in various diabetic studies that the renin-angiotensin blockage tends to reduce progression and incidence of diabetic retinopathy much better than the other blood pressure lowering drugs. We know lipid has some importance, but it hasn't been shown that statins actually reduce diabetic eye disease. However, there is some evidence that one particular lipid drug, fenofibrate, may be beneficial for our patients, and it's good for us to understand what this drug does. So the efficacy of fenofibrate for diabetic eye disease were established by two long-term randomized control studies, the ACCORD and the FIELD study. Both of them had 4 to 5 year follow-up. In the ACCORD study, they compared fenofibrate with a statin compared to statin alone, whereas the FIELD, they added fenofibrate versus a placebo, but the patients, if they were already on statin, continued with their old statins. So what they found in these studies were in the ACCORD eye study, fenofibrate did reduce the progression of diabetic retinopathy by about 30 to 40%. In the FIELD study, fenofibrate reduced the need for laser treatment for macular edema or PDR by about 30%. So 30% and 40%. So these are not insignificant effects. If you go back to the effect of lowering HbA1c and blood pressure, it's also around that 20 to 30% range. So fenofibrate does have a significant effect on the progression of diabetic eye disease. And what happened in the ACCORD follow-on study is after the trial completed at 5 years, they continued to follow up these patients. And most of these patients stopped fenofibrate after that. What they found was that the patients that had good intensive glycemic control still had a very slow progression of diabetic eye disease, whereas those who stopped the fenofibrate, the benefit of fenofibrate was lost. So the downside of this drug is, unlike good glycemic control, you need to take it for life in order to have that protective effect in the eye. I think there is a group that will benefit from this drug, and that tends to be the group that is at high risk of progression to vision-threatening retinopathy, and the group that has mild or non-center involving diabetic macular edema. So fenofibrate has our drug regulatory approval as a medication indicated for diabetic retinopathy, but we usually do give this in conjunction with the endocrinologist or family physician, because diabetic patients tend to have multiple medical problems, so many medications that the last thing the ophthalmologist should be doing sometimes is adding a drug without understanding the full systemic considerations. And there are considerations, for example, reduced dosing and renal impairment and so on. How about the other newer diabetic drugs? Do they have a benefit for the eye disease? The GLP-1 analogs have been shown to have a cardiovascular benefit, but didn't really seem to have a benefit for the microvascular complications like diabetic retinopathy. The same with the DPP-4 inhibitors. So what we do find is that all these new drugs seem to be very good for the cardiovascular, heart and stroke complications, but don't seem to improve the renal complications or the eye complications as much, because we believe it's a micro versus a macrovascular disease. So we've gotten the systemic management out of the way. Now let's talk about the actual ocular management. So the things that we will be doing day to day for our diabetic retinopathy patients. So as I mentioned, screening is important because it allows for early detection. And really what we do in most cases of early detection is to allow prompt laser treatment. And laser can prevent this vision loss. We know these are classic kind of images you would have seen from the ETDRS or the DRS study, where patients with a proliferative eye disease, if they were in the control arm and did not receive laser, they ended up with vitreous hemorrhage or tractional retinal detachment. If you do a good pan-retinal photocoagulation, they stabilize. So PRP is really a key treatment for diabetic eye disease and PDR. And we know from these studies I mentioned, can reduce vision loss by at least 50 to 60%. We can see the regression of neovascularization. We see in our clinic all the time. And these patients, if they don't develop bad diabetic macular edema, they tend to have a very good visual prognosis. They will lose some peripheral vision, but a lot of these PDRs that have been treated with PRP maintain very good central vision in the long term. And we know in a lot of countries where patients with severe non-proliferative eye disease can't be followed up regularly, we also do add PRP because we don't want to wait until they have PDR and have vitreous hemorrhage and TRDs before we treat. We also know laser used to be traditionally good for diabetic macular edema. We follow the ETDRS criteria, which is to treat CSME. But what people sometimes forget from these studies is that laser was shown to halve the rate of moderate visual loss, but very few people actually gained vision in these studies. And this is what we normally expect in some patients where, in this case, most of the leakage and the microaneurysms were extrafoveal, so it's a good candidate for laser. Laser was done of the microaneurysms and the hard exudates did resolve, the macular edema went away. So it does work well in some cases. But we know that, as I mentioned, vision gain is uncommon with patients who receive laser in those studies. And if you look at the control arms, they tend not to improve vision, they tend to maintain vision after laser. So we used to tell patients before anti-VEGF era that laser is to stabilize your DME, prevent vision loss, and some vision improvement may happen, but it's not the predominant objective. With anti-VEGF, and these have been around since 2006, I think in Singapore, the first injection was given 2006, 2007. It was Avastin because at that time, the other drugs were not available. And it's really changed the way we manage diabetic eye disease. We know the criteria. If you have center involving diabetic macular edema and your vision is worse than, or is 20/30 and worse, it is an indication for anti-VEGF therapy. Most countries started off with bevacizumab or Avastin, but now it's widely available to have ranibizumab, Lucentis, or aflibercept. These are the two other indicated drugs for diabetic eye disease. I'm not familiar with the kind of treatment you have in Indonesia, but in Singapore, because of cost issues, I think still 70% of our patients may receive Avastin or bevacizumab as a first-line therapy. So we know anti-VEGF drugs are extremely effective. This is data from the RESOLVE study, which compared Lucentis with sham. And obviously, the sham patients had poor visual outcomes. The patients that received Lucentis gained 11, 12 letters, 2 lines. That's a big difference at the end of 12 months. And the effect of anti-VEGF injections are maintained over time. So even if you follow them up after 12 months, they keep their vision up if they continue to receive regular injections. We know that anti-VEGF is better than our old standard of care laser. These are comparative studies that compare anti-VEGF, ranibizumab in this case, with laser only, or steroids in this case. This is the DRCNet Protocol I study. And we also know that adding laser doesn't seem to add any benefit. So if you did laser alone, anti-VEGF alone, or anti-VEGF with laser, you seem to end up with the same outcomes in the anti-VEGF group. And in fact, in a study where they compared adding laser deferred or at the onset of treatment for DME, they found patients that only had laser added as a rescue or kind of a second-line therapy in patients that don't completely resolve. They tended to have better vision than patients who had both ETDRS laser and anti-VEGF at the start. So deferring laser might be better. We also know that anti-VEGF needs some form of regular injection. It will always result in improvement of vision, and you tend to need many injections in the earlier phase of disease. What they did find in the DRCRNet protocols as well is in the first year, you tended to need about 9 injections, and that gets less in time. With time, and in spite of the decreased number of injections in year 2 and year 3, you maintain the same relatively good vision outcomes. And in their 5-year study, they found by 4th or 5th year, a lot of patients may not need any injections at all, but that's provided you treat it aggressively initially. So I feel that it's an important message for ophthalmologists. Patients may not get it at first, but in the initial 1 year, you really need to hit it very hard with the anti-VEGF, and then you get the benefits later. If you treat inconsistently in the first year, what we have found, because I think 10 years ago when we did our audit, most doctors gave 3 injections, stopped, and then they recurred, and the next year they gave another 3 injections, stopped. And we found that vision eventually got worse instead of better, and these patients needed some form of regular treatment many years after the onset of disease. So hitting it early is quite important in diabetic eye disease. But even if you find patients that are chronic, it still works. So this was one of the earlier anti-VEGF studies where obviously the treatment arm got injections, the sham arm just got laser. At the end of the study, the sham arm was allowed to get treatment, and they still had some vision benefit compared to the cases that got treatment with anti-VEGF from the start. So there will be some benefit, but they never fully catched up. So obviously chronic cases will benefit, but chronic cases don't do as well as if you had treated it aggressively early. We also know that in studies, these are the Asian studies for anti-VEGF, that there's no ratio or active difference in the effectiveness of anti-VEGF treatment. So no matter where in the world you come from, anti-VEGF works very well. And we also know, in spite of the fact there being so many drugs available, all 3 are very effective if you persist with the treatment, but there are some small differences in the visual outcomes. And in the DRCNet protocol T, what they did find was patients that started off with poorer vision, here was 20/50 or worse, tended to have a slightly better vision with aflibercept compared with bevacizumab. And this was mainly in this 20/50 or worse group. So in the eyes that present with worse vision at baseline, if they can afford it, there may be an advantage of giving aflibercept versus bevacizumab. But the difference is not big. Even in the bevacizumab group, they gained 13.5 letters, which is 2.5 ETDRS or Snellen line, which is already a big improvement. And the difference here is less than 5 letters, so less than 1 line. So really the guidelines have kind of changed. When it first came out, everybody was following 3 monthly injections and you try and do a PRN treatment. Now most people know that you probably need about 4 to 6 injections at the start for diabetic macular edema. And once they stabilize, you can try and stop the injections and try and extend the follow-up because they're less likely to need them as often. So we've gone from monthly regime, treat and extend or PRN, to more of a defer and extend once they stabilize to start deferring their follow-ups instead of treating at every visit. But we also know that a significant proportion of DME doesn't respond to anti-VEGF. So anti-VEGF is not a cure-all. Up to 30 to 40% of patients may not respond. And no matter which anti-VEGF drug was used, and this is from protocol T, you still had about 30% that didn't get the good visual gain or the good reduction of CRT at the end of 1 year. And most of the time after 3 or 4 injections, you can tell. So the group that responded very well, they responded within the first few injections. Those that never had a good response at the start just remained bad all the way. So that goes to the next strategy that you want to think about when you treat these patients. After you treat for 3 or 4 injections, should you switch? What should you switch to? People have switched between anti-VEGF, and that works for some patients, but not in all. And that could be because we know in the anti-VEGF studies for diabetic macular edema, VEGF is not the only driver of disease. A lot of times, there are other things that drives the diabetic macular edema. Inflammation is an important part of it. And we know that in a lot of real-world studies of VEGF treatment for DME, the results, you almost never get these 10, 11, 12 letter gain. And that is largely because people can't tolerate 8, 9 to 10 injections in a year. So if you're unable to tolerate a high burden of treatment, or if the anti-VEGFs don't work, do we have other options? They are. Unfortunately, these options do have side effects, and that's why they are not our first line. So steroids are an alternative that can be considered when anti-VEGFs don't work. We had trimethamlone for years. we know it works quite well, but a lot of them get cataract and high pressure eventually. So people have moved away from these short-acting steroids to slow-release, long-acting steroids, whether it's a dexamethasone implant like Ozurdex or a fluticasone implant like Iluvien. And we know these tend to work best in the pseudophakic eyes. And why? Because there is cataract. So if you give steroids, you must prepare your patient for the fact that they will develop cataract. And that's why it tends not to be the first line. In the Ozurdex study, they found that the pseudophakic patients had good improvement in vision, whereas the phakic patients initially had an improvement, then lost the vision because they developed cataract. But the amount of injections you need with this long-acting implant tend to be less because the duration of action is much longer. In a study from Australia that compared bevacizumab or Avastin compared with the dexamethasone implant, they found that the number of treatments you needed for bevacizumab tended to be in the range of 8 to 10, which is what we expect in the first year, whereas the dexamethasone patients generally only needed 3. And you found that the visual acuity was quite consistent, and this was with a consistent improvement. In fact, the improvement in central macular thickness with the steroid tended to be a little bit better. So what does this data suggest to us? In the pseudophakic group, steroids are a good alternative if you understand that patients may need some pressure-lowering medication, and the advantage is a much lower burden of treatment. So if you compare the treatment with an Ozurdex versus something like a ranibizumab, if they are equally priced, you would expect less visits for the patients with Ozurdex. So that is the advantage. But the disadvantage is they may develop cataract, and up to 30 to 40% may need IOP, intraocular pressure lowering drop. So there's not an insignificant side effect. But we do know with the slow release implants, most of them don't get severe glaucoma, the kind of intractable glaucoma where they lose vision and they need glaucoma surgery. So the advantage of these steroids is they can reduce treatment burden, which is an advantage in certain patients. And if anti-VEGF doesn't work, then they find that switching and switching early tends to provide some additional benefit, because a lot of times these are the patients where, if you remember our earlier picture of the pathophysiology, ischemia is not the only part driving the macular edema, but there's a lot of inflammation that also happens in diabetic macular disease, which is driving the swelling in these patients. So we've evolved from a kind of laser to anti-VEGF monotherapy to a treatment guideline that ties all of this together. If it's non-center involving, laser is still good. If it is center involving, if your vision is bad, it meets the treatment criteria of 20/30 or worse, anti-VEGF is really first line. But if anti-VEGF fails, then you may want to consider switching to an alternative like steroid. If they're pseudophakic and they can't come for monthly visits, that's also a fair indication to consider switching. And of course, in patients where you have high cardiovascular risk, you don't have the anti-VEGF potential side effects of cardiovascular complications in these patients if you use steroids. And of course, we must not forget that there are patients where there is diabetic macular edema with traction, and in these cases, surgery or vitrectomy with relief of the traction is an important modality to address the DME. So the important thing in DME is treat intensively early. You want to treat it hard, and treating it hard then allows you to tail off treatment later on. So the question that a lot of people then goes to, we have all this data on treating DME with vision that's 20/30 or worse. But we know in real life in our clinics, so if you've ever recruited for a randomized clinical trial, what we always find is there's a not insignificant, maybe about 20% of our patients that we pick up with this kind of appearance, with a few cysts, no SRF, positive for DME, central retinal thickness is 350, maybe even 400. When you refract them, they actually have 6.6 or 6.7.5 vision. So these cases were never evaluated in a trial. So the question is, should we treat these patients? People have always come to the conclusion that maybe we should, because if you look at the old ETDRS study, these patients with good vision these are the number of eyes that lost vision in the long, tended to lose vision with time. Whereas in the DRCR net, where everybody is treated, patients never lost vision. Okay, so it's a good thing that this group then attempted to understand or study this question because it's an important question. There are a lot of mild patients should we treat. What they did was assess whether patients with center involving diabetic macular edema with good vision needed to be treated. So they treated 1/3 of the patients with aflibercept. They treated 1/3 of the patients with laser, since ETDRS did suggest laser, and they just observed the other 1/3 of the patients. What they wanted to look at was the proportion of eyes that lost vision. And obviously, if any of this group, the visual acuity then got worse than 20/25 and met the standard treatment criteria of anti-VEGF, then they treated them with anti-VEGF. So they followed up these patients for 2 years. And immediately, the first thing you will notice is the patients with laser observation had a lot less visits over 2 years. Yep, because they did not require those 8 to 10 injections in the first year to try and treat the DME. And if you look at the amount of vision loss over 2 years, all three groups were quite similar. None of this was statistically significant difference, and they all hovered at around 15 to 16% that lost vision. So the conclusion for this is if you follow their protocol, observing rather than treating these diabetic macular edema with good vision actually would give you the same result. And their protocol is you still need to follow them up. You don't see this diabetic macular edema, tell them to go home, come back 2 years later. Obviously, they're going to lose vision because some of them eventually progress to need treatment. And if you look at these scores, they remain quite stable throughout the 1 year or 2 years. So there was no peak or trough where you ended up treating some patients and improving their vision. But they did find that about 25 to 30% of the patients in the laser and observation group eventually needed anti-VEGF injections. So what can you conclude from this? If your patient has good vision, you can watch it. 2/3 of these patients may never need an injection. It goes away by itself. Maybe 1/3 of them will need some injections over the 2 years. Rather than treating everybody, forcing everybody to pay for a drug, come back regularly, and have the risk of an injection. And although endophthalmitis or retinal tears are very rare, they can still happen. And these are the kind of illustrative cases where they had some amount of DME but good vision, and they were not given any injection, but in the end, the vision does stabilize and the DME seemed to stabilize. And so we do know that from this study, it demonstrates up to 2/3 of these cases may never need injection. So there really is no need for us to rush into treatment for these patients with good vision. And so as I mentioned again, there's no difference in vision loss. The majority of the observation and laser group never receive any treatment. So it is a very reasonable strategy to wait for vision loss to be significant before we start treating our patients with diabetic macular edema. This is a little bit different from age-related macular degeneration, where once you see a CNV or PCV, we know even though vision may be good, the majority of them do deteriorate with time. So the treatment strategy here is a little bit different. So we know anti-VEGF works very well for DME. Anybody who is given anti-VEGF also notices the first thing that one of the things that's obvious to use is after 3 to 6 months of treatment, their dot and blot hemorrhages go away. If they had a bit of ERMAs or NVEs, NVDs, they tend to go away. So we know anti-VEGFs also block the effect of proliferative diabetic eye retinopathy. So is it a good idea to treat these patients with anti-VEGF instead of laser? There have been 2 major clinical trials that tried to assess this question. The DR-CRNet protocol, which compared Lucentis with PRP, and the Clarity study in the UK, which compared aflibercept with PRP. The first study had up to a 5-year follow-up, which is good for us because our concern is always the long-term data, because we know if you hit them with good laser, in the first year you laser them a few times, after that they can be stable for life, which is fantastic. Whereas we tend to know with anti-VEGF, eventually the drug therapy may wear off, whereas this had only a 1-year follow-up. So what they did find was that really, if you compare the vision between injection and laser, at the end of 2 years, it was non-inferior. So there was no big difference. But of course, when you don't laser, you get less peripheral field loss. And also, interestingly, they found that you needed less vitrectomies with the anti-VEGF injections. And this was exactly the same findings in the aflibercept versus PRP trial in the UK, where they found that the visual outcome was similar or non-inferior between the two arms at the end of 1 year. Okay, so if you look at the visual acuity curve over time, what the benefit some people would argue is that when you treated eyes with injection, they tend to have kind of an overall better vision, although they ended up in the same place at the end of 2 years compared to the PRP first group. And this is really driven by people who had DME. So what we do know is that PRP is very effective for PDR. Anti-VEGF is also effective or is non-inferior. And there seems to be a greater benefit in eyes of DME because obviously we know you're killing two birds with one stone when you treat a DME patient with intravitreal injections. So let's speed up. So what really happens at the end of 5 years? Because that's our concern, right? I mean, you give them a few injections, we know it goes away, but do you need to keep treating them forever? So at the end of the DRCRNet 5-year study, what they found was that you really do need a lot of injections for this patient. So the PDR never really goes away. If you stop long enough, it tends to come back. So even the first 5th year, these patients were still getting 3 injections per year on average. So if you want to take up the strategy, you need to understand the treatment burden is going to be very high. And of course, if you look at the mean vision over time, there was no real vision advantage at the end of 5 years. So initially, you thought you had a vision advantage, but that really disappears. Initially, in the first year, there was a very big difference in the visual field. But with time, the visual field differences tend to narrow because this interesting finding is the peripheral vision also deteriorates in patients who have PDR who do not receive PRP. And in a way, if you've done a lot of angiograms, it is intuitive because if you do these angiograms in these patients, there's a lot of peripheral non-perfusion. And we know after you give anti-VEGF injections, the new vessels go away, the blood hemorrhages go away. But if you ever repeat the fluorescein angiogram, the non-perfusion is not there. So these injections aren't really treating the non-perfusion. It is just temporarily relieving the VEGF drive. So they also did a cost effectiveness analysis, and they really found if you didn't have DME, it's really not cost effective to treat with anti-VEGF compared to laser. If you had DME, you would be treating them with injections anyway. So the cost effectiveness of not giving laser and needing a few more injections seemed to be a little bit better. So those are our considerations, and really it is favoring PRP are fewer visits, fewer injections. It's more easily available. You have less problems with compliance because they need 20 injections. What if they stop halfway and disappear? And in all likelihood, they're going to come back with neovascular glaucoma. And we have seen that happen to our patients quite often. Whereas if you had a patient who lives next to the hospital who has insurance that covers all his medical costs and doesn't mind coming to see you every month, then there may be some small advantages in treating PDR with anti-VEGF alone. So my personal preference is not to use anti-VEGF monotherapy in the treatment of my PDR patients. So beyond anti-VEGF, are there any new emerging therapies? What we always hope for is that we have VEGF agents that last longer. There's actually a first agent that got, sorry about that, approval for as a longer acting anti-VEGF agent, and that's brolucizumab, or I think the trade name is Beovu. That was recently approved in the United States, but I don't think has got approval in any country in Asia yet. So Beovu is an interesting molecule. It is actually, instead of having the whole, in bevacizumab, it is a whole big Y-shaped antibody fragment. You remember that image from medical school? With ranibizumab, they cut off one tiny portion of the FC, and they still have that Y-shaped thing. With Broly, all they have left is the antibody binding site of the antibody fragment. So they can pack a lot of antibody binding site in a small amount of fluid. And they did show in the phase 3 studies for AMD that they were able to to extend to 3 monthly injections with a similar effect compared to more frequent injections with standard of care drugs like ranibizumab and aflibercept. However, this drug was released for use in the United States in December. And once you getting results from a clinical trial that has 500 patients is very different from letting a drug loose in the world and having 50,000 patients treated. And what they did find with brolucizumab in the first 50,000 patients is 1% develop severe uveitis or vascular occlusion. So the consensus on this drug is really still out there. If there are patients that really don't respond to what we have existing or have no way to tolerate the treatment burden, it probably does make sense to try to change to this drug when it's available. But we really need to keep in mind the side effect. And although 1% sounds like a fairly rare side effect, at the last meeting I was in the US before COVID closed all travel, I did speak to doctors who say when the new drug comes in, everybody wants to try it. They think it's going to be better. And when you take your patient that has AMD and who's been sick on Lucentis for the past 10 years, and then you give this drug and they develop uveitis and vascular occlusion, and they go to counting fingers, it can be a big impact. So we really need more data on the safety of these drugs. There are a lot of other potential therapies still in evaluation, like abicipar, the port device that allows you to have a refillable, slow release Lucentis in the eye, and various hydrogels that are trying to decrease the release of the drug so you can have a longer acting formulation. There are also other drugs that are targeting other strategies like faricimab, which is targeting not just binding VEGF, but also binding angiopoietin-2. And that's currently on the clinical trial. I mean, we are one of the sites for the trial, and it looks like it has some exciting potential. So I think we have really made a difference in diabetic eye disease with anti-VEGF, but because the pathophysiology of DME is very complicated, we are going to have a lot of new drugs that are going to come out that may be able to help us improve our outcomes in our diabetic patients in the future. But whether all these drugs work or not really depends on phase 3 results, because what works in a small number of patients or in the lab or in animal models do not always translate to successful treatment in humans. So the last bit, I'll just quickly talk about the indications for when everything else fails. And this is when you weren't able to screen them in time. Patients were perhaps not compliant with their laser, or you were not able to get enough laser in, or they fell into the group where, in spite of laser or anti-VEGF treatment, they still progress and develop complications. So when do we need to do surgery in these diabetic eye disease patients? The indications are quite standard. If you have persistent vitreous hemorrhage, if you have a dense premacular hemorrhage, if you have a tractional retinal detachment affecting the macular region, or which is associated with any tear or rhegmatogenous pathology. If you have severe fibrovascular proliferation, it also makes sense to do a vitrectomy. If you have neovascularization where there's blood or vitreous opacity that doesn't allow you to treat with PRP, or you have anterior hyaloid fibrovascular proliferation, these are also indications of vitrectomy. And lastly, as mentioned earlier, if you have DME with the presence of vitreal macular traction, very often you will find that VEGF alone will not resolve the DME because the traction or the vitreous pathology is an important part of the disease. And I understand this is mainly a group of general ophthalmologists, but we know vitrectomy has changed a lot in the past maybe 20 years. We have gone from 20 gauge to smaller gauge vitrectomies. We have gone from the slower speed cutters to high speed cutters that allows us to dissect even the most complicated cases quite successfully. But even in these cases where you eventually are able to get the whole retina basically flat and looking anatomically almost normal, we do know that the visual outcomes in this late disease tends to be very poor. So at the end of the day, the important thing is still identifying patients early. So screening is important, and ensuring these patients get the appropriate, adequate, and prompt treatment. So in conclusion, diabetic retinopathy management today, proliferative diabetic retinopathy and diabetic macular edema are the key causes of visual loss. It's important to screen because it's only with screening that you can detect these patients early, and earlier detection allows the treatment that can reduce vision loss. We know things like AI and new imaging modalities will allow us to improve screening and maybe better our follow-up and understanding of the progression of disease. A treatment in diabetic retinopathy has evolved from primarily laser to a combination of laser with anti-VEGF with other new emerging drugs and surgery. I think it's very important to emphasize, especially for general ophthalmologists and new residents coming up, that laser PRP is still very, very important. Okay, it's still crucial. It's our crucial tool in preventing diabetic blindness. Whereas anti-VEGF has emerged as a mainstay of treatment for DME, we must understand it has a very limited role in PDR and tends not to be useful in mild diabetic macular edema. And we are very hopeful that there will be many new therapeutic options that will emerge in the next 5 to 10 years, which will allow us to manage the disease better in the future and reduce the vision loss that diabetic patients would have experienced if not for all the treatment available. And with that, I end my talk. I thank you very much for all your attention. And I think we are open for questions or any discussion that anybody would like to bring up.
Okay, thank you very much for your great lecture, Dr. Gavin. So we all hope that the talk given by Dr. Gavin can give a valuable insight and contribute a lot to our field of study. Okay, now we come to another session of this meeting, which is discussion. So I will, there is so many questions already.
Yes, I see quite a few of them.
Yeah.
So how should we start?
Okay, I will read first 3 questions. So after that, you can answer it. So
Okay.
the first question is from Dr. Seskoati. How you build SIDRP, especially in the involvement of a general ophthalmologist or general practitioner, and what kind of tools that they must have, and what kind of training to them. The first question. And the second question from Dr. Hera is about SIDRP2. So is your SIDRP integrated with your national health systems, such as referral system, and is it applicable for a rural area? Okay, and the third question in the first session, still about deep learning. So in terms of vitreous haze because of hemorrhage, how far that the diabetic retinopathy screening technology such as Selena could endure the ocular media opacity and maintain its sensitivity and specificity. Okay, so please, your time to answer the question.
Okay. So let's take it from the first question. Okay. So how did we set up a screening program? Unfortunately, to set up any program, you need manpower and you do need a little bit of funding. The program was started as a kind of a small proof of concept project by my current boss actually in 2010. So that we got some funding to buy, actually it started with 3 locations, 3 funders cameras. The advantage in Singapore is there is a national primary care network. So these are clinics that kind of are essentially run by the government and they receive a government subsidy. And because of that, these clinics do get a lot of diabetic patients. So we started off by buying 3 cameras and putting it in 3 of these clinics. We got, obviously, the ophthalmologists can't be going down. So what we did was we trained nurses initially to take the images. So take the pictures. We trained the nurses to take the picture. When the program first started, obviously, the doctor did do the initial reading of the images. But we knew from the start it would not be sustainable for the doctor to do all the interpretation. So we also identified a group of technicians who we wanted to train in diabetic retinopathy reading. So although medical knowledge or maybe a nurse training is some advantage in identifying this disease, what we found is that at the end of the day, interpreting diabetic photographs is a lot of pattern recognition. So if you put anybody who is interested and motivated enough at looking at enough of these patterns, you can teach them how to grade diabetic eye disease. So we got the camera, we got the nurses in the clinic to do it, and we trained non-physicians to interpret the images. When we first started, the images were sent by kind of an FTP email because it was a small setup. Eventually, when we showed to our ministry that this program works, we were picking up disease, it was done in a cost-effective manner because the alternative was to send everybody else to the specialist eyes clinic. We were able to convince them to provide further funding. And then once we had the further funding, then we actually implemented a system where there is, in every single government primary care clinic, there is a camera. There are actually only 20 plus in Singapore, but these clinics are not the kind of clinics where there's one general practitioner running it. Most of these centers have about anywhere between 12 to 30 general practitioners. So these are big primary care centers. I'm not quite sure what the primary care setup is in your location, but getting GPs to do this as an individual is always very challenging because it may not be cost effective for one GP to buy a big camera. Okay, what we have tried to do with the GPs are two things. We have tried to set up like camera centers within where GPs are located so they can share one camera center. Or the alternative that some people have done is tried to buy the portable cameras. The portable cameras, when we first tried out portable cameras, maybe about 8 or 9 years ago, the image quality was quite poor. But today, the portable cameras, I think if your operator is well trained, gives you an image that's almost as good as the bigger fixed cameras. So that's the kind of components you need. You need to get the camera, you need to train the primary care person to do it. You need to have an ability to send the images. Today, I know in many places, they just do it over email or even WhatsApp, and you need somebody who can read it. And at the end of the day, for it to be sustainable, you need to find a way of getting it funded. So you really need to convince the government to put in some seed money, because without that kind of funding, it will usually not be sustainable. So our system has become kind of integrated. We created a dedicated telemedicine platform that then creates the referral loop automatically. And so it may not be so easily applicable to rural areas, but we have in the past worked with a few groups which have predominantly rural kind of outreach to set up similar programs. So we have worked with a group in Vietnam. We've worked in a few groups in Africa and in Central Mexico, actually, where they send people over to get training in the use of cameras and in grading the images. So these are non-doctors. And then they use them to go out into the community with portable cameras to then set up some form of screening system. And the answer to the last question, the AI is not, so it's very hard. AI will always be as good or at the best slightly better than humans. Why? Because in general, it is trained by using our human data. We use all the data we have from human grading to train the AI. And the AI can only see what is there in the image. It cannot see what is not there. So the limitations in terms of poor gradability, media opacity will not be overcome by AI. To address those, you need to overcome them with either better imaging devices. You know, the SLOs, because they use a laser instead of light to take the images, they can penetrate media opacity. Or if these patients have cataract, then you need to treat a cataract before you can really assess the fundus. So AI doesn't get away from that part. So the thing to really understand about AI is it's only going to deal with the interpretation of the image. You still need somebody to take the image. You still need to take a good image in order for AI to work, at least at this point of time.
Okay, thank you. So I think the keyword is funding and government support is very important for screening.
Yeah. Unfortunately, we can't get away from that. So yeah. I think in our experience, there was a lot of canvassing that needed to be done to kind of justify to the government it's worth spending the money. Yeah.
Yeah. Okay, thank you. And then for the next three questions. I will read the question from Dr. Harry Saiz is still about screening. So why non-mydriatic fundus camera is better than the mydriatic one in terms of sensitivity and specificity? And the second from Dr. Tigor, using SIDRP, have you encountered cases showing improvement between screening either NPDR or PDR, or do they simply worsen? I get the impression that this method can detect earlier and subtler things, thus being somewhat superior to manual screening. So how about your opinion? And the third question from Dr. Arfan, is it needed for ophthalmologists to give a neuroprotectant for early diagnosis of diabetic retinopathy, since it's still controversy for the pathophysiology, or there is any other way to avoid retinal ganglion layer thinning? Okay, maybe that's the second three questions.
Okay, so to the first question, just to understand, that was about the cameras, correct?
Yeah. Why non-mydriatic fundus camera is better?
Okay, so how non-mydriatic cameras work is there's a different lens mechanism. So whereas your traditional camera, you need a very large pinhole in order for it to take the image, the non-mydriatic can take it through a very small hole. And the light sensing device tends to be more sensitive as well. And because of that, they just tend to get better images in general, even if you have, and they're easier to use. So I think you get better sensitivity because you get better quality images overall. Because the lens focusing technology and the light capturing technology is a little bit different from the mydriatic cameras. So that's the advantage, that it gives you better sensitivity and specificity. In our own program, we still do dilate some of the patients when we screen, because some patients with cataract, even with a non-mydriatic camera, your image is going to be poor. But in those patients, a lot of them, all you need is to give a dilation, get them mid-dilated, and the quality of the images improve a lot. So patients that fail fundus photography without dilation, there is a protocol for our nurses to do dilation and then retake the photograph. Okay. The second question was?
Using SIDRP, have you encountered cases showing improvement between?
Okay, the improvement, yes. So we have looked at our data. So the limitation in our data is patients who reach moderate or worse tend to be referred. Okay, so once they go to moderate or worse, it becomes difficult to interpret what happens in this program. But we do know that if you take all the patients with mild non-diabetic retinopathy, the mild patients tend to get moderate or worse at an annual rate of about 3 to 4%, but about 1% of them actually do get better. So it's not a one-way, there is a transition between stages. We do know from our experience in the clinic, where I do have a cohort which is using wide-angle imaging to follow up these patients, there is a proportion of moderate patients that can go from a severely moderate, like an ETDRS 47, to maybe a less severe kind of pathology, like a 35 or 43. But once they get moderate or worse, they very rarely completely go away. In our context, we treat all our PDR, so we wouldn't see PDR going away. But we do know there are patients with PDR who sometimes turn up and they do have regressed new vessels. So that's not impossible. But we feel once you reach that level of severity, it's never going to go away. In a way, those moderate and mild cases can fluctuate between severity with time. So good control, I feel, is still very, very important. Okay. And the answer to the last question about neuroprotection. So I didn't show the data here, but I think there is very convincing data that diabetic retinopathy is a neurovascular disease. Which came first is up to debate. Some people debate the neuronal changes drive the vascular changes, but most of us believe it's primarily vascular. Neuronal can be primary, like any neuropathy, or it can be a secondary. The problem is we honestly do not have a good neuroprotective drug. There was a big randomized controlled trial with neuroprotective drugs that was run in the not in the UK, in Europe by the ESTAC group. The ESTAC is the European Diabetic Society's eye complications group. We collaborate a bit of some of the people who ran the trial. So what they did in this trial was to try and use alpha-GAN and somatostatin, which are known neuroprotective agents, in patients with diabetic eye disease. And at the end of the 5-year trial, they found that these drugs did not make a difference. Okay, whether there are other neuroprotective drugs that might make a difference, or maybe it's the fact that topical alpha-GAN doesn't get into the retina, because we know topical drugs don't penetrate well. That isn't really answered yet. But at the moment, I don't know of many other neuroprotection trials, because to be honest, most of them have failed. And most of the neuroprotective trials in neurology, a lot of them has failed as well. And I mean, I spoke to a neurologist about this quite recently, and they feel a lot of times it's about the way the drugs are delivered. In the lab, it's very easy to deliver a neuroprotective drug in a petri dish to the neuron. In the body, it tends to be very difficult to deliver the right concentration of the drug to where you want it to work. And that might be one of the barriers. And once you can deliver that drug, it's very hard often to prove that it works. So unfortunately, at the moment, neuroprotection is not a pathway that has been successful. And we know a lot of other drugs that try to prevent progression have failed, like the PKC inhibitors failed as well. But there are at least 3 or 4 drugs upcoming in phase 1, 2 from companies which don't normally do eye disease, like Merck and Boehringer, who have drugs that tend to modify the way the neurovascular disease happens. They don't call them neuroprotective because the effect may be largely vascular, and those will, I think they are planning phase 3 trials probably in the next 5 years. So maybe there will be other drugs that will help us prevent the progression of the disease in the future, in addition to what we have now.
Yeah, okay. Thank you, Dr. Gavin. It's all clear, but we still have a question. Yeah, we have several questions from Dr. Reva. He asked about in DME, non-center DME, is still used that we do the grid laser at area that non-center to DME, because according to his experience that there is no advantages for laser compared to anti-VEGF. So what is your opinion? And next question is from Dr. Sony. So he asks you, do you give the diabetic or hypertension medication by yourself or refer to the internist? And can we give anti-VEGF as the first line therapy for DME? Is there any contraindication or not? And the last question from this session from Dr. Eru, he asked about what could we do best for case of DME patient who haven't good compliance because of multiple systemic diabetic complication and might misvisit the schedule. Okay.
So the first question about the role of laser, I think it's quite clear if you have center involving DME with poor vision, really laser doesn't work, okay? But we do know laser is still being used. I mean, there are a lot of places I've spoken to doctors in Africa where they just don't have access to cold chain for anti-VEGF. They may still do laser, okay? But in most places in the world where you can get anti-VEGF, the role of laser has really reached zero in those cases. Where laser may still have some role is in patients which have non-center involving DME, which meets the ETDRS criteria. What we do know is that laser may reduce their chance of getting center-involved DME by about 30%. it's not high. So that becomes then a discussion for your patient. Does your patient want that some preventive benefit? And because it's not high, we will anecdotally see a lot of patients that progress anyway. Or do they want to wait until it reaches the center and get injection? I feel it's a discussion that I would normally have with the patient. Because my patients often can come back for good follow-up, we are doing laser a little bit less and a little bit less. But there are patients who I know may not be able to come back for regular follow-up that I may still do laser in this population, not to improve vision, but to prevent vision loss. In the group where there is center involving, but the vision is too good for injections, you can see the results from the DR-CRNet protocol. Whether you laser or you observe, the result tended to be quite similar. So there didn't seem to be a big effect on the laser. But if you looked in the fine print of the study, it was not a primary outcome, but the laser group, a very slightly less proportion ended up needing injections compared to the observation group. It was not statistically significant, but the sample sizes, once you do such small analysis, is never going to be enough. So there may be that small advantage of laser there. So in these two instances, you can consider laser, but as your colleague has quite rightly mentioned, the effect is going to be very, very small. So you need to discuss with the patient if it's going to be worth their while doing it. So the second question again.
Do you give the diabetic or hypertension?
So no, we don't give hypertensive or diabetic medications ourselves. The only drug that I may sometimes start myself is fenofibrate. And that's just because there's very poor education among GPs about the benefit of it. And the thing about fenofibrate is there is an intolerance profile. With fenofibrate, I think about 10-20% of patients don't tolerate it because they get bad muscle ache. It's not going to kill them or cause like liver damage or anything, but they get bad muscle ache and they will refuse to take it. So in patients where I feel may benefit, where control is good, but they're still progressing, I may start a trial of treatment and I'll give them a letter to see their GP in 2 to 3 weeks. If they don't get the side effect, then I tell the GP, if there's no other contraindication, please continue. If they get a side effect, then it stops there. But I don't manage it long-term unilaterally because in our eye clinic, it's not set up to even with drugs like fenofibrate, you still have to monitor liver function tests every 6 to 12 months. So there are certain things that we are not set up to do. And yeah, even more so with the newer diabetic drugs and the newer hypertensive drugs, usually we'll get them to see the diabetic physician. I mean, in our own setup, that we do have eye clinics in a diabetic center. So it's actually just one floor up. So that makes it quite easy if we need to. Yeah.
Okay, so the third question is about the compliance of DME patient to give the injection.
So we find that compliance is... So I can't tell you if it's compliance by the doctor or the patient, but like I mentioned to you earlier, when we first did our DME treatment when I first did it in 2010 or 2011, we found that compliance with injections was very poor. In our current audit, we actually find most of our patients get more than 6 injections in the first year. And I think it's a matter of, firstly, the price of the injections have come down. The government subsidy for the injections has improved. Obviously, money always matters, but it's also because more and more people are getting injections. So I think among the diabetic and elderly population, it's almost become socially accepted that some people need the injection. So they understand their friend needs it. I need it too. If I don't comply, it does make a difference too. So we do find compliance is a lot better. And it's a combination of, I think, more patient awareness as well as doctor awareness, plus the fact that the subsidy has improved a little bit. It's not a huge amount, but any little bit makes a difference. And just to note, the majority of our patients still receive bevacizumab for cost reasons. I'm not sure how it is in your situation. I know in some countries, they just cannot give it because it's an off-label and they're not allowed to give off-label drugs.
Yeah, okay. I think if about anti-VEGF, the problem is about money usually.
Yes, usually it is.
Yeah, okay.
Yeah.
The next question, okay, from from Dr. Eka. So when we decide the patient with DME doesn't respond to anti-VEGF treatment. And then from Dr. Yasmin, so are there any consideration to do the anti-VEGF injection during this pandemic season? And the third question, I think this is the last question. So how long we use fenofibrate since it has so many systemic complications? I think he already answered it, but if there any worsening, is it possible to uptake the doses or? Okay, so please answer the question. Okay.
Okay, so when do we switch? I think there has been fair data to show us that if there's zero response after 3 to 4 injections, it's not likely to work. Okay, so if you get zero response, or you will see some of these patients after 3 to 4 injections, conversely, they get worse. We do see that once in a while. These guys are just not going to get better. And those patients, if they are pseudophakic, I would switch to a steroid quite quickly, because I mean, we don't really have very much other options at the moment. If they are phakic, then I may switch to another anti-VEGF first. Okay. If there is some response, so in incomplete responders, I tend to persist if the patient can be compliant. So if they can come for regular injections, I will often wait for at least 6 to 9, because we know in the incomplete responders, a lot of them do respond better after 6 to 9. So I tend to dichotomize in those two groups. If I get no response, I will consider switching early, especially if they're pseudophakic. If it's a partial, I will persist a little bit longer before I switch.
And then
the next question.
About how about using anti-VEGF in this pandemic season?
Yeah. So okay, I think there are 2 stages where you need to consider. The first stage to consider is when you are in some form of lockdown. I'm not sure if you are, but we are in some form of lockdown right now. We have cut our clinic volumes to less than 30% because the government told us to. And we do know that patients with diabetes, all these are very high risk. So we have generally restricted injections to patients with only eye or bilateral disease. Because if you know, if they have only one eye, if you let them get bad, you may lose the vision altogether. And if it's a bilateral disease, then they can lose both vision. But what we have done for some of these patients, and the advantage for us is if you're on Avastin, the government system actually pays for your whole cost. They would come in just for the injection without doing any assessment, and just so we can tide them over until the situation stabilizes. So we try to minimize their contact with doctors and other patients, so we try and minimize spread. And right now in the clinics, we are using surgical mask. When you are doing procedures where it's close to the patient, the advice is to try and use goggles or a face shield, especially if you don't wear glasses, because the splatter can affect. And we've installed kind of like shields on all our slit lamps, so that if patient coughs in the slit lamp, it's not going to cough respiratory secretions into our face. So that's what we've tried to do. But the injection volume really, I think we were looking at a statistic that day, we dropped from the whole center from doing 100 over injections today to about 20, which is what we expect. Because I think if you include AMD, about 20% of our patients may be only eye or have bilateral disease. Yeah.
Okay, thank you. And the last question about fenofibrate. Yeah.
So fenofibrate, again, I don't tend to give it long-term myself. Actually, the side effects of fenofibrate tend not to be serious, okay? If you look at the 2 long-term trials, very few patients, they were worried about kidney disease and liver disease. The number of patients having severe kidney disease or liver disease was not statistically significant in either arm. So, but the only side effect is they do get a bit of body ache. If the patients can tolerate it, it tends to go away after a while, but some patients just don't like the body ache and they won't take it. So yeah, the problem with fenofibrate, and I have had some cohort of patients where they actually improve with fenofibrate, but you can't tell because it's not a randomized control study, right? But we've tried to, those patients, if they don't have side effects, are often very happy to continue taking that 1 pill a day. The thing about fenofibrate is we don't know if the response is dose dependent. So we don't escalate the dose. There is a standard dose to give depending on the formulation. The problem with fenofibrate, again, is there are many formulations. So if you're not very familiar with it, it's easier to get the physician to give it. Depending on the formulation, the milligram dosage is different because fenofibrate absorption in the gut is not great. The bioavailability is not great. So in the raw form, usually you give a 300 milligram dose. Whereas in the form that is lysophilized or micronized, you can give a lower dose because it's better absorption. And what I do is I adjust for renal status. So depending on the eGFR, there's a chart on whether you should half the dose or 1/3 the dose. Yeah, but you don't give a higher dose. It's not known to be a dose response curve. And of course, the effects at a higher dose are really unknown. So I would not do that.
Yeah, okay. So giving fenofibrate is not common. We use it for diabetic retinopathy here. So
yeah.
Okay, so I think the last question from Dr. Mutiara and Dr. Chesa marks the last session of this webinar meeting, also end of this meeting. So again, I would like to appreciate Dr. Gavin for today's talk. We really hope that after your talk, after your giving lecture, so our knowledge will be much better after this meeting. So another appreciate also given to head of Indonesia Ophthalmology Association Branch Malang or Perdami Cabang Malang Raya, and also all of the committee and also all of the audience. So I think it's time to say goodbye. Thank you for your kind attention. So stay safe and Assalamualaikum warahmatullahi wabarakatuh. Okay.
Yep. Thank you very, very much for your attention. I think the questions were wonderful and very, very appropriate. And I hope to be able to visit Malang sometime in the future. Yeah. And hopefully we can work out some collaborations as well. Yeah.
Yeah. Okay. Thank you.
Okay. Take care.
Yeah.
Yep. Bye-bye.
Bye.